a lot of rhythms right here, okay, guys? So normal sinus rhythm, you have a P wave, you have a QRS, and you have a T wave. That's how you know that you have normal sinus rhythm. It's usually between 60 and 100 beats per minute. The P wave always precedes a QRS. The PR interval between the P wave and the next complex is usually 0.12 to 0.20 seconds. And your QRS is very narrow, usually less than 0.12 seconds. All these elements here constitute normal sinus rhythm. Let's talk about some abnormal ones now. Oh, one more thing. I want to put emphasis on the fact that, look, this is the P wave, which represents atrial depolarization, which means the atrias are firing off their electrical impulses. Look at the size of that complex as opposed to the ventricular repolarization, meaning that the ventricles, the T wave represents the ventricles when they're relaxing. And notice that even when the ventricles are relaxing, their complex is bigger than the atrias when they're actually contracting, or at least when they're firing off the impulse. Because all of these rhythms, guys, don't mean shit if there's no pulse. So you always assess the pulse. But my point is, the ventricles are really strong. Look at this QRS complex. It's so high. The reason why I'm emphasizing this is because when you guys are looking at the rhythms, you first have to find out, okay, is this atrial or a ventricular issue? And the way we do that is with the following. If you have P, Q, R, S, T, that's normal sinus rhythm, 60 to 100, it looks pretty good, right? But what if you have this? Now, I know I've made the QRS a bit narrow, but let's pretend it's normal. But do we see a P wave? There's no P wave. There's no definitive P wave. So, but I could still see what? The QRS, I could still see the T wave. And what do those two represent? The ventricles. This is absolutely an atrial issue because I could still see the ventricles doing their thing. The atrias, even if there's something wrong with them, generally speaking, they're not going to mask any of the ventricular electrical impulses because the ventricles are relatively small in their output of electricity compared to the ventricles. So that's how you distinguish, is this an atrial or ventricular issue? By looking at this one, there's something wrong here. So at least I know it's an atrial issue. And when it's quivering like that, we call that atrial fibrillation. Keep in mind that atrial fibrillation can cause blood clots. So these patients are going to be on blood thinners. You have to look out for altered level of consciousness because it means that the blood clot might have gone to the brain. What do we have this? Again, what do we see? What do we not see? I see something weird here, but I could still definitely see the QRS and I can still see the T wave. So that means that the QRS and T wave are cool. That means the ventricles are doing just fine. This is an atrial issue. And we call this atrial flutter. Okay. So what you got to do is just memorize what the rhythms are. But what do we see this? So for this one, remember, we're looking for PQRST. Do we see a P wave, a definitive P wave? No. Do we see a QRS? Not how we're accustomed to see them like that, not like that. Do we see a T wave? No. So what's the only part of the heart that is strong enough when abnormal, it'll hide all other rhythms? The ventricles. This, by the way, happens when you eat too much McDonald's. And this is ventricular tachycardia. This is VTAC. Okay. What about this one? Oh, before we actually talk about that one, with this whole VTAC thing, notice that in VTAC, it's still predictable. There's a particular rhythm to it. It's uniform. You can guess where the next complex, what it's going to look like. So because of that, those are the features of ventricular tachycardia. But what about this one? It's chaotic. There's nothing, I don't see a PQRST. So I know for sure it's a ventricular issue. But because it's chaotic, it's non-uniform, we know that this is ventricular fibrillation. Okay, and we'll talk about the interventions of these in just a bit. Yeah.
But how would you prove that it's not something with the atrial?
Because if it was, well, even if it is something also wrong with the atrial, that takes second, who cares? It takes a back burner because the ventricles are the ones that are pumping blood. And that's what we actually have to address. That's why, no problem. All right, he said that you don't have to know heart block, but let me just talk about it real quick. This is normal sinus rhythm, right? Sort of, I know I drew a little ugly. In the heart, you have the SA node, you have the AV node, you have the bundle of His, You have the right and left bundle branches in the Purkinje fibers, right? So the impulse is supposed to go this way, but then the AV node right here creates a pause. That pause is reflective of the PR interval. It's supposed to be short, just a fraction of a second. But we want the electricity in the atrias and the ventricles to be open so they can get filled up with blood. And that's what that AV node does. It creates a pause, and then the rhythm goes to the ventricles, and then it subsequently allows the ventricles to contract. When you have a heart block, that pause becomes prolonged. Let me show you what I mean by that. So you'll see something along the lines of P, Q, R, S, T, P, Q, R, S, T, P, Q, R, S, T. That's how you can distinguish a heart block. This is normal. The PR interval is supposed to be less than 0.20, but right here, you notice that it's getting longer and longer. That's a heart block, and that's a problem because the ventricles are not going to pump, and that can cause death. That can cause syncopal episode. The blood's not going to where it's supposed to be. Heart blocks are dangerous. There's 3 types. They're Mobitz 1, Mobitz 2, which has 2 subcategories, and that's the Mobitz, excuse me. And then so you have first degree, you have second degree, Mobitz 1, Mobitz 2, and then third degree,